So we are starting a new subject, that is dermatology. So we will try to cover it in minimum time possible with concepts and mnemonics. So to understand the dermatology, you have to understand the physiology of skin. So in liver, let's assume liver. So what, to understand the liver, we have to understand the normal physiology. Then we will go for pathology, diseases of liver. And in every organ, there could be infection, so infection of liver. In every organ, there could be tumor, so tumor of liver. So if we try to study anything, then we have to first understand the normal physiology. Then we will go for pathology. Then we will go for infectious disease, then tumor. This is the sequence we will follow in any diseases. Okay, any subjects, any organs. Okay. So basically in dermatology, you have to understand the diseases of skin. There are many diseases which present with skin lesions. So there are various type of lesions, various types of skin diseases, various types of cells present in epidermis or dermis. So we have to understand all this to know the pathology of any disease. Okay, so first start from the skin. So in skin there is epidermis. So epidermis has 5 layers: stratum, corneum, lucidum, stratum lucidum, granulosum, spinosum and basal. So how will you remember this sequence? It is very easy. Basal to base पे ही होगा, last deepmost layer. Okay, corneum, cornea is on outer layer of eye. So corneum सबसे बाहर होता है. So in this case also stratum corneum is outermost layer. Then LSG, LGS. What is LGS? Stratum lucidum, then granulosum, then spinosum. This you have to remember. Okay, these are the layer of skin. These are the layer of epidermis. Now you can see this picture. You can see this picture. This is stratum basal. Okay, this is stratum spinosum. This is granulosum. This is lucidum, and this is stratum corneum. So you can see in this stratum corneum, there are so many keratinocytes, but these all are dead keratinocytes. There is no any nucleus present in this layer. You can see this is spinosum, so many keratinocytes, and these are connected by desmosome. This is desmosome which is connecting these two keratinocytes. Okay, basal cell has columnar, basal layer has columnar cell. So columnar cell will reach to the stratum corneum, and at that time they dead at stratum corneum. Okay, and the time from stratum basal to stratum corneum is 28 days. It took 28 days from stratum basal to reach stratum corneum. Okay, now each layer has different function, different organs, different granules. So in lucidum, it is lucent, translucent layer. It has illidine granules. Granulism name in itself written as granules. So it has keratohyalin granules. It has profiligerine, which is converted to the filigerine. Okay. Spinosum. Spinosum is like nucleus spinosus. Okay. So there are so many desmosome which is present, which is connecting the keratinocyte. Okay. Now let's talk about each layer. So stratum corneum, you will find flat cells. You can see in this patient. Okay, and it has keratinized layer. It has had dead cells. Stratum lucidum, it has translucent, has had illidine granules. Granulosum, I have already explained you. It has keratohyalin granules. Then next is Odland bodies. Odland bodies are present in stratum granulosum. So which act as a barrier to skin. We have stratum basal, which is the columnar cell with central nucleus. It is present at basal layer. Okay, so we have now 5 layers: corneum, lucidum, granulosum, spinosum, basal. After that starting of dermis. This is layer of epidermis. So we have understand the normal physiology of epidermis. Now dermis. So this is epidermis projection into the dermis. This is known as retirages. And dermal projection into epidermis, this is known as dermal papilla. Okay, so projection of epidermis into dermis, retirages, and projection of dermis into epidermis is dermal papilla. Okay, now we have understand the layers. Now there are various cells present in epidermis. So melanocyte and Merkel cell both are present at basal layer, and Langerhans cell and keratinocyte, these are present in spinosum layer. You can see in this patient, these are the keratinocyte and Merkel's and Langerhans cell. These are present in spinosum layer. You can see melanocyte and Merkel cell, these are present in basal layer. and melanocyte has melanosome. It originates from the neural crest layer. Okay. Langerhans cell has sub. What is sub? It is originate from. It is present in spinosome. It is antigen presenting cell. Has Burbeck granules. It is a dendritic cell. Okay. So these are the 4 type of cell present in the skin. And Merkel cell and keratinocyte both are ectodermal origin. So these are frequently asked question. If you solve the MCQs of any coaching institute, you will find that there are so many questions on the layer of origin. From which layer of origin keratinocyte is from which layer of origin, so you have to mark the answer ectodermal. Okay, so I have told you that keratinocyte, these are the keratinocyte, these are connected by desmosome. So there are so many desmosome, and desmosome has protein desmoglein 3 and desmoglein 1. So desmoglein 3 and 1, if there is antibody against these desmoglein protein, the disease is known as pemphigus vulgaris. If it is against desmoglein 3, if it is against desmoglein 1, then the disease is pemphigus foliaceus. Now we have understand about the epidermis layers and epidermis cells. Now we are going towards the dermal epidermal junction. We know that epidermis is the outermost layer. Then we have dermis layer. And the junction of epidermal, epidermis, there is dermal epidermal junction. And dermal epidermal junction, you can see these are the hemidesmosome. These are the hemidesmosome, which has BP 230 antigen. It has lamina lucida, lamina densa, and collagen fibers, which is present in the dermis. So this is dermis, this is epidermis, and this is dermoepidermal junction. Okay. So if antibodies against hemidesmosome, so disease is known as bullous pemphigoid. Okay. So if antibodies is against desmosome, then it is pemphigus vulgaris. If it is against the hemidesmosome, then it is bullous pemphigoid. So it has layers hemidesmosome present, lamina lucida, which is anchoring filaments, lamina densa, which is anchoring fibrils. Now dermis, we have learned about the epidermis, dermoepidermal junction. Then we have dermis. So dermis has papillary and reticular. Papillary has 1/10 part of dermis, which is loose connective tissue, and 9/10 is covered by the reticular dermis. And the most common type of collagen present is collagen type 1. Okay. After the dermis, there is hypodermis, which has subcutaneous tissue. So subcutaneous tissue inflammation, if there is infection is in that subcutaneous tissue, and that is known as paniculatus. So we have understand that it is epidermis, then we have dermal epidermal junction, then we have dermis, then we have hypodermis. Hypodermis is subcutaneous tissue. After that we have muscles. So this is the layer. So we have to just understand, we have to just learn about the diseases at this level. We don't need to study anything extra in dermatology. Okay. Now we have learned the epidermal layer. Now there could be many changes in any layer, in each layer. So first is hyperkeratosis. So what is hyperkeratosis? It is, there is so much keratin, there is thickening of stratum corneum. You can see in this patient, there is thickening of stratum corneum. This is known as hyperkeratosis. It is seen in psoriasis and hypergranulosis. You can see in this patient, this is hypergranulosis. So this is seen in lichen planus. So lichen में क्या होता है? Hypergranulosis, and absent granulosis is seen in psoriasis. Okay. And what is this parakeratosis? So para मतलब क्या होता है? There is something abnormal, like Olympic होता है, then Paralympic. What is Paralympic? Paralympic is Olympic of physically handicapped. Okay, so parakeratosis is something abnormal. So what is something abnormal? There is present of nucleus in stratum corneum, which is not usually present in stratum corneum, but in this case nucleus is present in the stratum corneum, so it is known as parakeratosis. So we have learned about the parakeratosis. So in parakeratosis, you have to understand that it is the nucleus which is present in stratum corneum. Normally it is not present. Okay, then stratum granulosum. So in stratum granulosum, there is hypergranulosis. So you can see there is multiple granular layer. So hypergranulosis seen in lichen planus, and absent granulosis seen in psoriasis. Okay. Next is acanthosis. Acanthosis is thosis. Thosis मतलब thickening of spinosum. Thosis, acanthosis is thickening of spinosum. Stratum spinosum, it is ballooning degeneration. It is seen in herpes simplex virus. It in stratum spinosum. So what is spongiosis? So spongiosis is edema in spongiosum. So what is spongiosis? Spongiosis is intracellular edema. Intracellular edema of epidermis, meaning there is fluid accumulation between the keratinocyte. Okay, this is seen in spinosum layer. Okay, dyskeratosis, it is abnormal premature keratinization. Normally keratinization is start from the stratum basal layer and it goes till the stratum corneum. But if there is abnormal premature keratinization, then that is known as dyskeratosis. Then Monro microepsis. What is Monro microepsis? So present of cells, present of group of cells, present of neutrophils in corneum layer, it is known as Monro microepsis. And if it is present of neutrophils in corneum, so we have understood that it is Monro microepsis. If it is present at spinosum layer, then it is spongiform pustule of Kogoch. Okay, now we have papillary tip. So if there is papillary tip microepsis, it is present on papillary tip. Okay, then it is dermatitis herpetiform. So we have learned about the papillary dermis and reticular dermis. So if it is present at papillary tip, then it is seen in dermatitis herpetiform. Next is Poitier microepsis. It is atypical T cells. So these are seen in mycosis fungoids, Poitier microepsis. Okay, atypical cell present. Now retinitis. There is regular elongation. You can see this patient. This is regular elongation. So this is seen in psoriasis. And you can see lichen. Lichen is sound like it is sharp. Lichen. So you can see this is short tooth ridges, sharp retinitis. Okay. So this is the difference. Okay. So now we have understood about the epidermis layer. We have understood about the dermis layers. We have understood about the pathological changes in various disease in these layer. Okay, now because we have learning about the dermatology, so there are various skin lesions. So what are the various skin lesion? So there could be primary skin lesion or there could be secondary skin lesion. So primary skin lesion is, it is the initial skin lesion to appear. Secondary is, it is the modified skin lesion. It is due to itching and treatment. Okay, so primary skin lesion, first is macule. Macule is due to non-palpable, it is non-palpable flat skin lesion. So macule नाम में क्या लिखा है, दबा कुचला सा लग रहा है नाम. So it is, that's why it is non-palpable. If it is less than 1 centimeter, then it is macule. If it is greater than 1 centimeter, then it is patch. Okay. Now we have solid raised lesion. So if it is solid raised lesion less than 1 centimeter, it is papule. Greater than 1 centimeter, it is plaque. If you can see these, this is macule. You can see in this there is non-palpable less than 1 centimeter. It is greater than 1 centimeter. And you can see this nodule greater than 1 centimeter plus depth is present. Okay, this is nodule. Now we have papule. Sorry, less than, this is non-palpable and it is macule. If it is greater than 1 centimeter, then it is patch. Patch is like एक धब्बा है, एक धब्बा सा है ना, that is patch. Okay, now papule is, it is less than 1 centimeter and it has solid raised lesion and it is less than 1 centimeter, that is papule. If greater than 1 centimeter, that is plaque. And if it is greater than 1 centimeter and depth is present, then it is nodule. Okay, so this is solid lesions. Now we have lesion which have fluid. So if it is less than 1 centimeter and fluid is present, then it is vesicle. If greater than 1 centimeter and fluid is present, then it is bulla. Okay, so these are the lesions. These are the primary lesions. Okay, so are you getting my point? These are the initial. So we are learning dermatology. So you have to understand, in dermatology we have to understand the various type of lesion, skin lesion. So first we have learned about the non-palpable lesion, that is macule. Macule is less than 1 centimeter. Patch is greater than 1 centimeter. Okay, now we have solid raised lesion, that is papule, in less than 1 centimeter. Plaque is seen in greater than 1 centimeter. Okay, next is nodule. Nodule is greater than 1 centimeter plus depth is present. So you can see in this picture, macule is non-palpable, papule is You can see solid lesion. Nodule is solid lesion with depth is present greater than 1 centimeter vesicle. Now we have petechiae. So what is petechiae? So petechiae is 1 to 2 centimeter lesion, 1 to 2 lesion, that is petechiae. Greater than 3 that is purpura, RBC extravasation, and greater than 1 centimeter is ecchymosis. So it is, if it is non-palpable, then macule patch. If it is solid, then papule. If it is at fluid, then vesicle and bulla. Okay, now we have secondary skin lesion. So secondary skin lesion, it is modified skin lesion. It is due to treatment or scratching. So first is scale. So scale is exfoliation of stratum corneum. Okay, crust is hard exudate, drying of serum on skin. It is seen in non-bullous impetigo. So erosion, loss of epidermis is erosion. Fissure is deep cleft in skin. So if it is deep cleft in skin, then it is fissure. Lignification, continuous scratch leads to hyperpigmentation. Okay. Next is atrophy. So loss of structural component of skin, that is atrophy. Now we have learned about the primary skin lesion, secondary skin lesion. So let's talk about the specific skin lesion. So specific is burrow. Burrow is like gufa. Burrow is gufa. It is seen in scabies. So this is epidermis. This is dermis. So it forms this type of lesion in epidermis. This is burrow. Now we have comedon. So comedon is seen in acne. So what is comedon? Comedon is follicle which has sebum with keratin. So it is present in acne vulgaris. These are the specific lesion. Okay. Now we have understood. You can see these structure. So this is papule. You can see solid lesion. Solid lesion, you can see papule. You can see this is closed comedon because these are white, and open comedon has black. It has opening, so it has blackheads. You can see nodules. Nodules, we have learned that it has depth and 1 centimeter, greater than 1 centimeter in length, and these are solid lesion. So obviously papule and pustule, if we will touch, then they have solid lesion, and vesicle has fluid filled lesion, and bulla also. Okay, so now we have understood about the skin lesion. Now there could be pattern of lesion. So if vesicle arranged in a cluster, you can see in this case, this is herpes labialis. So if vesicle arranged in a cluster, it is seen in herpes labialis. Okay. And if it is annular arrangement, then it is tinea corporis. If it is resembling line, then it is a linear configuration. So lines in dermatology, Blasco lines, epidermal cell migration pathway you can see in this patient. Now there could be various investigation. So various investigation. So first is Nikolsky sign. So what is Nikolsky sign? So if you apply a tangential pressure, upper epidermis is separated from the lower layers. This is true Nikolsky sign. So it is possible due to acantholysis. So what is acantholysis? So keratinocytes are connected by desmosome. I have already explained to you, these are the various keratinocytes. These are connected by desmosome. So if autoantibody formed against the desmosome, these keratinocytes disintegrate, and this is known as acantholysis. And so if you will give, if you apply a tangential pressure to upper epidermis is separated from the lower epidermis. So it is present in pemphigus vulgaris, foliaceus, and staphyloskeletal skin syndrome. Okay. Next is pseudo-Nikolsky sign. So because we have understood that acantholysis leads to true Nikolsky sign, because acantholysis leads to separation of keratinocyte, and pseudo-Nikolsky sign, it is due to necrosis of keratinocyte. So because of necrosis of keratinocyte, it leads to pseudo-Nikolsky sign. Next is erythema. So erythema is redness. So redness due to vasodilation or due to any reason. So if you apply the blanching, if you apply the pressure, these redness disappear. This is known as erythema. And in purpura, it is due to RBC degenerate and staining the blood vessel. It is known as, purpura, it is non-blanching response. Okay. Next is dermatological investigation. So dermatological investigation, Wood lamp examination. So 360 to 364 wavelength is used. It is made up of filter. Gallium silicate and nickel oxide is used. Okay. So you can see in wood lamp examination, you will find different color on different fungus or different diseases. So in microsporum, it is green. Trichophyton scloreni, it is blue. Pityriasis versicolor, so V से आपको याद रखना है, it is yellow color. Erythema, it is red. Erythema, it is like erythema, so it is red. PCT, Porphyria cutaneata, pink color. Congenital erythropoietic porphyria, red teeth. So Wood examination shows different color on different diseases and in fungus. Next is laboratory examination. So KOH mount. So KOH mount is used in fungus. So chromoblastomycosis, copper penny bodies you will find on KOH mount. So these all you have to remember because these can be asked in exam. Pityriasis versicolor. So you will find spaghetti and meatball appearance on zinc smear. So how there is another way, another investigation cytodiagnostic test, that is zinc smear. So there is a fluid filled lesion. So you have to deroof the lesion, scrape the floor and roof, and then see in the Gemisa stain. Okay. So you can see in this acantholytic cells, pemphigus group of patient. Therapy, cryotherapy, it is used in liquid nitrogen, it is used for warts and keloid. Phototherapy, it is used in psoriasis, vitiligo, atopic dermatitis. Okay, so we have learned about the basics about dermatology. So in first we have learned about the layer of epidermis, that is stratum corneum, then lucidum, then granulosum, then spinosum, then basal. We have learned about the layers of epidermis. We have learned about the retiregis and dermal papilla. We have learned about the cells, melanocyte, that is neural crest origin. Merkel cell, this is originated from the basal cell. So melanocyte and Merkel cell both are present in basal layer. Then Langerhans cell and keratinocyte which are present in the spinosum, and Merkel cell and keratinocyte both are ectodermal in origin. Dermoepidermal junction, we have BP2AG protein. Okay, we have learned about the hypodermis. We have learned about the various dermopathological terms, that is stratum corneum, hyperkeratosis, parakeratosis, granulosum, hypergranulosis, absent, acanthosis, spinosum, spongiosis, diskeratosis. We have learned about the various type of lesion, that is primary, macule and patch, solid raised and vesicle or bulla. We have learned about the various secondary skin lesion. Okay, we have learned about the pattern of skin lesion. Okay, dermatological diagnosis, true Nikolsky sign, pseudo, lab investigation we have learned about. Okay, so this is the basics of dermatology.